I have the great pleasure of introducing our SAGES president, Dan Smith, for his presidential lecture. And before I turn the podium over to him, I'd like to say a few words about him. Every president puts his or her personal stamp on SAGES. The perspectives have been wide and imaginative, and we've all been the beneficiary of each of our leaders. It's been ever more challenging for them to make the society better, but Dan has certainly made his mark. He wasn't actually born as a professor of surgery, although it may appear that way. He's worked diligently along to get to this space. We've all benefited from the roads that he's traveled. Dan has served on the SAGES Board of Governors since 1999. He has attacked his responsibilities as first vice president, chair of the Continuing Education Committee, co-chair of the Guidelines Committee, and chair of the 2006 annual meeting in Dallas with gusto. There are those who say he almost killed himself trying to make the 2006 program the best ever. You can see him here with his injury. Notice that his arm is not in his sleeve. The secret's out now. He broke his arm during a friendly football game in Dallas the day before the meeting. A new SAGES law stemming from that episode, known as the Program Chair Non-Football Rule, will prevent me from killing Brian Duncan in 2011, the program chair next year in San Antonio. More seriously, Dan has worked hard on the Conflict of Interest Task Force, an issue that took center stage during his presidency. He recently completed a 2-year term as president of the Fellowship Council as well. He's been there for the serious work and the joy of being in the SAGES family. He's been here for the controversial and also for the mundane. While not devoting his time and energy to SAGES, Dan maintains a busy clinical practice focused on the management of esophageal diseases and minimally invasive surgery. His scholarly work includes over 100 publications in peer-reviewed journals, 25 book chapters, and invited presentations all around the world. He serves on the editorial board of several surgical journals and serves on the committees of national surgical organizations in addition to his work with SAGES. His family will soon have a little more time with him, which is well-deserved for this dedicated husband and father. Couldn't resist these youthful photographs. On a personal note, I'm very proud to call Dan my friend. We've grown up together at SAGES, sitting first in the back rows and later at the board table. We've talked about kids and about job choices, and I'll take this moment to thank Dan for preventing me from making some bad ones along the way. And we've encouraged each other through the transitions of adulthood. I'm very proud to introduce to you the man whose work has eased my path as next year's president, SAGES president, Mr. Dan Smith, Dr. Dan Smith.
Thanks, Joe.
Redskins bring 4. Breeze, double pump, still can't find anybody. Retreats, throws it downfield into a crowd, and that is going to be intercepted. Coming up with it is Kareem Moore.
Moving to his left, across the 40, up to the 45-yard line. The ball is stolen away. Robert Beecham takes it, and he's going to go all the way for a touchdown.
12-0 champions of the NFC South.
Great play. One of the best plays in football this past year. There were 11 people on that field who knew before that play exactly what they were going to do. They all had plan A. Clearly, this was not plan A. This was plan B. And that's what I'm going to talk to you about today, is everyone knows plan A, but it's really all about plan B. I'm going to define it for you. It's pretty intuitive. I'll give you a few examples. I'm going to try to share with you why I think this is sort of a relevant theme in surgery. Talk about plan B in my practice and plan B in my personal life. Definition's pretty clear. This is nothing new to anyone. Plan A is the principal plan of action. Plan B, therefore, then, is the alternative plan if a principal plan of action is unsuccessful. It's the backup plan. Now, in executing a backup plan, there are all sorts of variables that both force the need for a backup plan and prepare an individual to be able to execute that backup plan. Oftentimes it's called luck. We've all heard luck favors the prepared mind or the prepared body, spirit.
That one might have been two-man where they play underneath man coverage with two deep safeties. Very difficult to get the ball downfield. Snap on second down, four-man rush. Orton pumps once, throws. Pass is going to be tipped and caught. Stokely's got it. Here we go. 40, 35, 30, 25, 20, 15, 10, 5. To the house. Holy cow. The end zone. And I have to sit down.
Just like they drew it up in the playbook, Dave. Just like they drew it up in the playbook.
Well, clearly not how they drew it up in the playbook, but maybe different than that first example. To execute that plan B, that individual had to be prepared, had to be able to take on the maneuvers to catch that football, orient themselves, and run the right direction. So it does favor the prepared mind. Now, sometimes plan B and a successful plan B has virtually nothing to do with what the individual does. Plan A here is to finish and win a medal, which means going faster than everyone except two other people. This was not happening for Apollo Ono. So that probably looks a little more like luck, because there really wasn't anything that Apollo Ono did there, at least not in that race. We saw maybe some things he did in a few others, to get himself in a position to be successful, even though plan A wasn't really what got him successful here. It was others' errors. Sometimes plan B has everything to do with something you've done. I'm sorry. But the outcome, again, can be favorable, even though what you've done probably isn't what you intended to do. So in the Winter Olympics this past year, German team actually won a gold medal. This was a gold medal performance. Not plan A in exact execution, and in fact the execution failed because of the individual, but the outcome was still favorable. So there are lots of variables that affect plan A, plan B. Some we have under our control, some we don't. Some plan Bs require simply courage and the drive to survive. And some of you may remember this back in 2003, a hiker who found himself trapped alone on a hike with his arm stuck. And the only way to get out of that situation was to actually amputate his own arm. Plan B took nothing but just courage and a desire to survive in that case. And then there are the very dramatic plan Bs, where it is really the combination of many of these different factors: courage, skill, training, a calm demeanor, and a spirit that can get you through to a successful plan B.
700, climbing 5,000.
This is a simulation, but the real transcript, or the real voices.
Departure to contact, I maintain 1-5000. Maintain 1-5000, Cactus 1549.
And I want you to listen to the calm in the pilot's voice.
Cactus 1549, turn left heading 270. This is Cactus 1539, hit birds, so you're lost thrust on both engines, returning back towards LaGuardia. Okay, you need to return to LaGuardia. Turn left heading up 220. 220. Tower, stop your departures, got emergency returning. It's 1529. He bird strike. He lost all engine. He lost the thrust in the engines. He's returning immediately.
Cactus 1529. Which engines?
He lost thrust in both engines. He said.
Got it.
Cactus 1529. If we can get it for you, do you want to try to land runway 13?
We're unable. We may end up in the Hudson.
All right, Cactus 1549. It's going to be left traffic to runway 31.
Unable.
Okay, what do you need to land? Do you want to try to go to Teterboro?
Yes.
Teterboro, Empire, actually LaGuardia departure guy, emergency inbound.
Hey, go ahead.
Cactus 1529 over the George Washington Bridge, wants to go to the airport right now.
Wants to go to the airport. Check. Does he need assistance?
Yes, it was a bird strike. Can I get him in for runway 1?
Runway 1, that's good.
Cactus 1529, turn right 280, you can land runway 1 at Teterboro.
We can't do it.
Okay, which runway would you like at Teterboro?
We're going to be in the Hudson.
I'm sorry, say again, Cactus? Cactus 15.9, radar contact is lost. You also got Newark Airport up at 2 o'clock in about 7 miles. Eagle 54718, turn left heading 210.
So you heard at the end of that broadcast, the directions from the tower, the answer, we can't do it. Where would you like to land? We'll be in the Hudson. Calm. We all know the outcome there, but the outcome from that was driven again by preparation, skill, courage, the desire to survive, all these different features that led to Plan B and a successful outcome. We all know in our real lives about Plan B. I mean, we've been living this now for the last couple of years. The financial crisis, none of us expected that. The Bush administration and weapons of mass destruction that really didn't turn out the way Plan A was meant to be. The number of retirees who are back to work, 90-year-olds who have to go back to work because of an unsuccessful Plan A. So all of us in our real lives are pretty familiar with this. SAGES has become very familiar with this, not only because of the financial impact recent changes has had on this organization, but Joe Beiske mentioned the conflict of interest issues and the industry relation issues that were thrust upon us unexpectedly this past year. So I hope I have, in general, seeded with you the concept about why Plan B is so important. But let me turn to surgery now and talk a little more specifically about why I think this is a topic I chose for a SAGES presidential address. We all know surgery is probably one of the most complex interfaces, human-to-human interface. We have limited tolerance for errors. Now the airline industry has a similar model, but they fly the same plane every day. And there's only a limited number of planes they fly. Clearly not our scenario. Every patient in every case is absolutely unique. And we as an organization have spent a lot of time developing new Plan A's. Plan A used to be open chole. Well, we developed lap chole, or helped develop lap chole. So we've been on the forefront, actually, of trying to transform surgery by developing and implementing new Plan A's for surgical care, and doing that very well. But as we do this, there are lots of variables that drive the success of this. And I would submit there are sort of 4 elements, or 4 areas in which we all have to work and consider when we talk about a successful Plan A. Obviously the patient, the surgeon, the system in which we provide that care, and the intervention itself. Each has different components or different variables that we have to attend to. The uniqueness of the patient, their anatomy, their comorbidities, and their ability to comply with what we ask. And the surgeon level, not only our skill and experience, but maybe some more fuzzy kind of things like our humility, our metacognition, and our skills in situational awareness. The skill and experience of our systems in supporting us with infrastructure and resources, and then the intervention itself. The outcome that we expect, the complexity of the case, the technology we use, and the patterns of failure are all important variables for a successful Plan A, and they all represent places where Plan A may break down and where Plan B may need to be implemented. Also, when we think about an episode of surgical care, we can also see the places where Plan A starts, but also the places where we may need to change and think about a different Plan A, from pre-op through the operation, through the early post-op period, and then out into the long term. So we're dealing in a very complex system. We all have a Plan A when we start. Our teams, our nurses, our patients all know what Plan A is, but then we have to execute in this very rich, very dynamic environment. And what I want to do with you today for this next part of this talk is I'm going to focus a little bit on this recurrence failure, the long-term outcome piece of Plan A, and draw a couple of pages from my own practice. And I'm going to submit that there may be times when Plan B actually needs to change Plan A right at the beginning. Now, I'm going to be a little controversial here. There are going to be people in the audience I'm confident will find me afterwards and not be happy or will strongly defend against some of what I'm going to say. And that's the privilege of being the president and getting at least 30 minutes to say whatever I want to a couple of thousand people who kind of have to listen to me. My practice, let me just tell you briefly. I do about 200 foregut procedures a year in addition to a background of general surgery. About 40% of my practice over the last decade or longer has been redos. So if you just do the math, I'll do roughly, or have done roughly in the last 10 to 15 years, anywhere from 2,000 to 3,000 foregut procedures, and about 800 to 1,200 redo foregut procedures of varying types. Nissens, hiatal hernias, some bariatric redo. Hellers are becoming more common redo procedure for me. But what I'm seeing a lot of right now in my practice is the recurrence after a hiatal hernia repair. This is a fairly controversial area right now about how should we be fixing these hiatal hernias. Well, here's what we know. We know that the anatomic failure after a primary tissue repair is 30% or greater. And I bet a show of hands in this room would pretty much concur with that. We also know that use of mesh will decrease the short-term failure rate to around 10%. There's prospective randomized data that supports that statement. We also know that the concept of mesh to repair hernias is already well established for abdominal wall hernias. Now we can argue, and I've been a part of these arguments, that the diaphragm is a different muscle, it's a different part of the body than the abdominal wall. But hang with me, just in general, conceptually that for many has not been a big leap to take mesh to the diaphragm. So I would submit at a reasonable conclusion, and I think a fair number of people in this audience have come to this same conclusion, and that is use mesh to repair hernias. Plan A. Well, I've obviously been involved in foregut surgery for quite some time, and have seen some of the disadvantages of that approach. Was able to be a part of a study with several other very notable authors, and we looked at a series of 28 cases where mesh had been used in a hiatal hernia repair and the patients needed a reoperation. Now, I show this slide, I'm not going to go into this, but I show this because I want you all to know I understand the difference between the bioprosthesis and the permanent. And I know the pros and cons. My comments, I hope, are from a fairly informed place. But this is what we found in that series of patients. The video is showing one of the procedures where a piece of commercially available preformed mesh was involved in obviously a case of a recurrence. But you'll see on the left in the column a couple of things I want to point out. One, all types of mesh were involved with redos, even biomesh. Two, dysphagia was a fairly common problem and reason for reoperation in these patients. And three, you see that a fair number of these patients needed major resection. 6 esophagectomies, 2 gastrectomies. Well, this certainly piqued my interest. And we wanted to go a little bit further and find out in our own mind, should this pattern of failure maybe change our thinking about Plan A? Now, this is on as a plenary tomorrow with one of my fellows. He gets all the credit. I don't want to steal his thunder, but I am going to show you one slide from what is going to be presented tomorrow. And this is the results of a series of patients over about 3 years, 78 patients who had reoperative foregut surgery, 10 who had had prior mesh, and 68 who had not. And we looked at need for major resection, the ability to complete a fundoplication, and a few other outcomes. And just in a nutshell, what I see from this is that the patients who had mesh placed, who ultimately need a redo, there's a significantly higher risk of a major resection needed, i.e. esophagectomy or significant gastrectomy. And there's a decreased likelihood that you will be able to remediate in those patients with a fundoplication compared to when no mesh is used. So let me take us back to the theme. It's all about Plan B. So we go back to the premise. Mesh decreases hiatal hernia recurrence. That's Plan A. However, mesh does not eliminate recurrence. patterns of failure when mesh is used are far worse than when mesh is not used. And I'll tell you, my plan A, based on an understanding of plan B, I won't use mesh, or I'll only use it when it's impossible to get tissue closed. Now, before you either run out of the room or attack me, let me get through with this, because I think what I really want to communicate to you all today is how important it is to be aware of plan B when plan A doesn't work. Know why it won't work and how it doesn't work and what impact it has overall, and then rethink your plan A. Again, sort of to look at it a little differently, if you did 100 hiatal hernia repairs without mesh, 30 or more would recur. About 10 of those, and this is published work, about 10 of those would actually need a revision for their anatomic recurrence. And maybe one might need a major resection, but it won't be an esophagectomy. And this is published, this goes back 7 years now, based on another series of ours from Emory. Same, 100 patients, you put mesh in, 10 will recur. Boy, that's a great improvement. 10, though, are going to come back with dysphagia, bad dysphagia. And of those, 10 of those 20 are going to probably need another operation. And in that situation, up to 2 to 3 are going to wind up with an esophagectomy or a major resection. So, we work in a very complex system. I've picked just one small segment of what we do in surgery to try to highlight the concept that we all know plan A. But when we work in systems as complex as this, there are so many places where plan A will break down. We all need to be prepared to execute plan B. And it's not just exit strategies. It's not just converting in the operating room. It's not just recognizing the complication in the first 30 days, but it also even includes this long-term outcome piece that we really need to attend to. And I think we as a profession and we as a society need to continue to develop and focus on new plan A's, but I think we should really be paying attention to remediating and doing a better job with plan B. I think our healthcare reform is going to demand that before we get something new that might add cost, we've got to make sure that what we're already doing today, including when plan A breaks down, is optimized and the best that it can be. Well, let me transition and finish this up by talking about plan B in my personal life. You saw a few of these slides already, but let me put them in context. This is me with my son Eric. I was a third-year medical student. No, second-year medical student. This is me with my daughters, Catherine and Brittany, twins, and I was a fourth-year medical student. This is the family. This is about third year of general surgery residency, or maybe fourth year of general surgery residency, 4 of 7. Now, kids, plug your ears. This was not plan A. They don't know that. They think Cindy and I had this all, figured out, but this was not plan A. But I got to tell you, sometimes plan B is the plan A you could never even conceive or dream of. Although I guess I did conceive of this plan. I did conceive this plan B, didn't I? Yeah. And I want to move into sort of my thanks part of this time, and I really appreciate you all indulging me to be able to say thanks to my family. These guys are the plan A that I never, ever could have envisioned, ever. I'm a better person because of them. I'm a better surgeon. I'm a better doctor. I think I'm a better friend to an organization like this. And I think much of what I've been able to achieve was that change in my life. That plan A that all of a sudden dissolved and turned into plan B that has me standing here today, and I wouldn't be here today doing this. I know that because I was off thinking about other things and heading in a different direction. So that's why I think maybe you might appreciate why for me it's all about plan B. I'm not smart enough to figure out plan A, and a durable plan A. And in my personal life, I live that every single day. And I'm very grateful for you guys to be my new plan A. And hopefully, I'll say this to my family directly, that hopefully being here today has made some of your plan Bs around what I've sort of put you through make it all worth it or better. And a few final thanks, and these are obviously very important things. I've had the privilege of working in a lot of different institutions with a lot of different people. And I really need to thank my partners. I've had solid partners everywhere I've been who've provided significant support, insight, helped me through some difficult times. At the University of Cincinnati, and particularly Mike Nussbaum, who was my first partner in practice. At Emory, John Hunter was a significant partner and colleague to me. My other Emory partners, Bruce Ramshaw, Lena Caton, Ed Lynn, Scott Davis, were all a significant part of that life. And a special sort of shout out to a friend at Emory was Aaron Fink. Aaron was somebody who was very important in my involvement in this organization. And any of you who've gone online to the SAGES website and seen a little video address I have up there about how to advance in SAGES and how to get involved in leadership, I acknowledge Aaron there also. Aaron was really a critical person for me in introducing me to this organization. At Mayo, Horacio Asbin, I know you're out there somewhere, S.P. Bowers and Ron Landman. So partners are critical to be able to do anything like this. Fellows, I've had the privilege of training about 27 fellows over the years. And this is as close as to a thanks that you guys will ever get. And don't ever think that I'm gonna come down any lower than that from you guys, okay? And SAGES members, to all you, hundreds of SAGES members, we are a meritocracy. We are a group of professional friends and colleagues in this room who work together in service to our patients and in service to this organization. And a few of us get an opportunity to sort of get in the front of the group, but it's really only leading with the support of all of you that has made this capable. And finally, the SAGES staff, the BSc management, Sally Matthews and her team, are critical to the success of this organization and anyone who stands at this podium in this role. So thank you all very much for the privilege of being your president this year. It has been an honor and truly a pleasure and a once-in-a-lifetime experience. And before I finish, Sally, if you could just come on up here. I've got a little gift I want to give you, and then we'll move on in the program. So thank you. Sally Matthews.
Very inspirational speech. I'd like to present Dr. Smith with a plaque, his presidential plaque from SAGES. It has a gavel on it. And it reads, "The task of the leader is to get people from where they are to where they have not yet been." From Henry Kissinger. With gratitude for your leadership of SAGES, presented to C. Dan Smith.
Thanks, Joe. Thank you. Thanks. Really? Good. I'm glad. Here, let's get a picture. Can we get a picture together? Whoops. Glasses off.